Good morning, good afternoon, good evening, students. Welcome to Capstone. Welcome to the first of the 5 topics, which is fever. If you have not already listened to the Capstone intro audio, please go ahead and do that. Hopefully it will give you some perspective. So let's get started. So the objectives of this talk are that we should be able to list differential diagnosis for fever across the systems. We should be able to evaluate a patient with fever using 4 steps of epidemiological approach and recognize urgent and emergent situations. We should be able to order appropriate labs and imaging after clinical evaluation, and in the end we should be able to recommend appropriate treatment based upon the diagnosis. Now, most of the material in this talk has already been covered in systems courses at various points. So you are already familiar with it, but there are some things that are probably new, but hopefully it's pretty easy to follow. In the end, of course, if you have any questions, you can always send me an email or call me or contact me anyway, and I'll be happy to reply. The best way to utilize this material would be to go through it in its entirety and listen to the entire audio. Hopefully this will bring everything together. So let's get started. Fever is a symptom that runs across the systems, and there are multiple categories of diseases that can present with fever. So the first one and the most important is infection. Whenever we see somebody with fever, the first thing that comes to mind is infection. We'll talk more about that. The next 2 categories are malignancy and connective tissue diseases, and then there is drug fever, which is an interesting phenomena where people can take prescription medicines and instead of getting rid of fever, they can actually develop fever, and we'll talk more about it later. And then the last thing is fever of unknown etiology or origin. That is fever that has lasted more than 3 weeks, and despite workup you don't know what's causing it. So we see that too, but hopefully we don't see too much of it. So anyhow, how do we differentiate among all those categories, and how do we know what category our patient belongs to? So that is the next step. This is probably one of the most important slides in this DSA, so please do pay attention to it very well. Now, the first thing when we see a patient with fever, after making sure that the patient doesn't have any red flags or alarming symptoms and signs, the first question should be really duration of fever, because that quickly brings you down to one or the other 2 categories of infection or malignancy or connective tissue diseases. So this is a very good or highest yield question because it broadly differentiates among categories. And then of course the grade or severity of fever is important, and constancy is important too to some extent. So do make sure to ask about duration. If it is acute duration, then infections generally speaking are going to be the cause, and in that, if it is high grade fever, then you can start thinking, okay, it is probably bacterial infection. And in addition to that, generally with bacterial infections, people have focal symptoms. That means symptoms are limited to one part of the body. If the fever is low grade, then we sometimes start to think that, okay, maybe it is a virus infection, and then usually with viral infections, people have constellation of symptoms. For example, a patient with otitis media will probably have fever and pain in the ear, so that is a focal symptom and high grade fever. But a patient with upper respiratory infection, which is usually a virus, that person will have congestion and cough and runny nose and headaches and all kinds of different problems in that part of the body, and that points toward the direction that maybe it is a virus infection. Now, there are extremes of ages. For example, very young and very old age people, they don't really follow this rule very much. So for example, elderly patients may not even develop high grade fever, or very young kids may not develop high grade fever even if it is bacterial infection. Alright, so the next is chronic fever. So if a patient has had fever for quite some time, and generally speaking we call a fever chronic if it is more than 3 weeks, but again there can be some overlap. Then you start thinking about either connective tissue disorders or malignancy. So these 2 categories will start to become more important here. And whenever there is weight loss present as well, then we say okay, this may be a cancer or malignancy. So this is the next high yield question to differentiate between these two categories. And then if there is skin rash, which is another very high yield question for connective tissue disorder, then we say, okay, maybe it is this as opposed to malignancy. And then also in that case, we see that patients usually have a lot of joint pains and aches. And with these two categories, people usually have constellation of symptoms again, so they don't really have focal symptoms as much. Usually they have malaise and fatigue, and they also may have generalized bone aches and pains. With low-grade fever, with these two categories also, generally they have low-grade fevers. They don't usually spike high-grade fevers. Alright, so this is a snapshot of general approach to a patient with fevers, and what are some of the most important initial questions that we should ask. So duration would be the most important, and then so on and so forth. Alright, let's go ahead and look at all the pathologies or all the diseases that we are going to cover as far as infections are concerned. So of course there are more diseases that can cause fever, but I'm limiting myself to just this group of infections for the sake of this talk. So you can see all the infections starting from head to toe, and then you can see key features, symptoms and signs on this side. So this is just like the high yield finding, so I'll just talk about it real quick. So for example, you can see a patient with meningitis can have headache and seizures and loss of consciousness, and patient with otitis media will have earache. Pharyngitis patient may have sore throat, and then you remember red pill diagnosis. This is a set of diagnoses in ear, nose and throat, where whenever people have these diseases, they can have drooling, which usually is a red flag situation where we must take action, because this means upper airways getting obstructed. Patient with pneumonia will have cough and shortness of breath, and then endocarditis and myocarditis patients usually have shortness of breath, and especially myocarditis patients usually have chest pain. Sometimes endocarditis patients don't have chest pain as much, they just have chills and fever. And then gastroenteritis patients have diarrhea and abdominal pain. Again, I'm only talking about infectious colitis where patients have fever, and generally those are bacterial, so I'm not talking about viral gastroenteritis where they don't have fever. Cholecystitis patients usually have right upper quadrant pain, and then in the abdominal pathologies, usually people have nausea and vomiting. So this is just like a very common symptom that many diseases share. So this means that we should not base our diagnosis on this finding alone. Sometimes people in other parts of the body, for example meningitis and also a pyelo, can get nausea and vomiting, so just be aware of that. Patients with appendicitis will have right lower quadrant pain, and then cholecystitis and cholangitis will have right upper quadrant pain, and the differentiating feature between the two would be presence of jaundice and cholangitis. Then you can see patients with PID or pelvic inflammatory disease will have pelvic pain, usually in females, and patients with prostatitis will also have pelvic pain in men. Patients with osteomyelitis usually have localized bone pain, so it's not generalized bone pain that we see in malignancy, it's localized. And then septic arthritis patients should have localized joint pain, so not multiple joint pains that we see in osteoarthritis and other things. So along with that, a very significant feature is that they have extremely reduced range of motion. And then spinal abscess patients usually have localized back pain along with fever. So you must keep that in mind, because back pain is a very common symptom, and when and how and why should we consider spinal abscess as opposed to just regular old kind of back pain is when we have a patient with fever now as well. And then there are 4 other infections right here. These are non-focal infections usually. So for example, patients with flu and HIV, malaria and TB, they can have a lot of constellation of symptoms, and these infections affect multiple parts of the body, so therefore there is no focus. But the good thing for us, at least for diagnosis purposes, is that there are lots of risk factors attached to these infections, and if we can identify the risk factors, then we can make the diagnosis more easily. In addition to that, we have the other 3 categories: malignancy, connective tissue disorders, and drug fever. So we'll talk more about that later, but this slide is just to show how there are some high yield findings for all the infections, and then different diagnoses are common in different age groups and populations. So some clues in the history can give us more help, and let's talk about that here. So here I just kind of added a little bit epidemiological information. So we can see that certain age groups are more predisposed to certain infections for whatever reason, and again, these are just general rules, so this is not hard and fast or absolute. Infections can cross all kinds of different age spectrums, but generally speaking, meningitis and encephalitis patients and pneumonia patients can be any age category, so they can be very young or very old. Those are the two most common, and then everything in between as well. But otitis media and pharyngitis and red pill patients are usually young, so they are not very old. People or adults do not really get these infections very much. And then endocarditis and myocarditis patients are usually adults. They are not very young. Most of the time, gastroenteritis, cholecystitis, and cholangitis patients are adult patients, and you can see that female patients usually get cholecystitis more often, and usually those are the ones who are in their 40s, and sometimes they are overweight. Patients who present with appendicitis, generally they are very young. And then pyelonephritis patients can be young or old females, and then elderly patients as well. So pyelonephritis is one of the most common infections in nursing home patients. And then PID is generally female patients, and then prostatitis is generally men. Osteomyelitis, spinal abscess, and septic arthritis patients are going to be usually your adult patients. Septic arthritis patient can be very young as well, so children can come in with one joint infection. And then influenza can affect anybody in the world, so that's why anybody can get flu, so keep that in mind. But of course this will be more in the flu season. Now there are special risk factors or special populations that that are more predisposed to HIV and TB. So for example, immunocompromised patients will get it, and people who already got HIV are at high risk to get TB. And then malaria and TB is also going to be more common in patients who have traveled recently to endemic countries. So this is just a general overview of what age category is going to be predisposed to what infections, and hopefully this will give us some more perspective, and when we are seeing patients, it helps us make the diagnosis more easily. All right, so let's get started with individual diagnosis here now. Oh no, we're not there yet. Okay, so just one quick slide on epidemiological approach. So how do we use epidemiological approach? Well, you already are familiar with it very well. So first, when you see a patient, you make sure you build your prior probability, and then you look for vital signs to make sure the patient is hemodynamically stable and there is no red flag situation. If there are additional symptoms present with fever, then you start asking questions about that system. So for example, if somebody comes in with fever and diarrhea, then of course you will ask about abdominal pain and nausea and vomiting and everything like that, and then it makes your job easy. But if you don't have any focal symptom, then basically it's free for all. So you just need to ask questions from every single part of the body, so and hopefully you will get some positive answers, and that's how you narrow your differentials. And of course, in addition to that, we don't just stop there. We ask more questions to rule out all the more likely diagnoses. So therefore we remove our anchor bias. So this is how we use epidemiological approach, and we'll come back to it later. All right, so now let's start talking about individual categories. So we have meningitis, encephalitis, and intracranial abscess. And whenever people have infections in the cranium, then they have a constellation of symptoms or symptoms of the raised intracranial pressure. So this is extremely important to remember, because all of these infections will present with most of the time a combination of these symptoms. So people have fever, headache, and this headache is going to be very special headache, so it's not your regular kind of tension or migraine headache, this is going to be one of the most severe headaches. And also people have more headache early in the morning after they've been lying down for a while, because that's when their pressure has increased. Also, this headache is going to be worse with bending over, worse with any maneuver that raises the intracranial pressure even further. In addition to that, people have photophobia and neck rigidity, and you can see that meningitis patients usually have these the top 3 symptoms more common, and then neck rigidity. And encephalitis patients usually have more altered mental status and fever as opposed to the other symptoms. So they very early on they develop altered mental status, and of course, come on, this is the brain that's infected, so they are gonna, of course, develop altered mental status. Intracranial abscess patients have not only all of this, but they can develop seizures and altered mental status as well, and they in addition have nausea and vomiting, because the pressure is raised so high that now they start to develop nausea and vomiting. On top of that, the signs of these infections, the common signs would be papilledema on eye exam, neck rigidity or nuchorigidity, and Brudzinski sign and Kerning sign. So you're already familiar with these signs. Whenever you're suspecting these pathologies and these symptoms are present, then look for these signs on physical exam. And then when you are suspecting these infections, and of course these will be the labs and tests to order. CBC is important to see if there is any systemic infection, and CT scan is extremely important to perform whenever you are suspecting any space occupying lesion. So keep in mind that this is extremely important, because if we do a lumbar puncture before doing a CT scan, then that can cause brain herniation, and that is a scenario that we absolutely do not want. So whenever you're suspecting an SOL, such as intracranial abscess, that is a space occupying lesion, or a subarachnoid hemorrhage, then we must do CT scan before we do the lumbar puncture. And one thing about subarachnoid hemorrhage is that this is another problem. It's not an infection, but of course it's another disease or pathology where people can have all of these symptoms. So sometimes these patients present with low-grade fever and the rest of the symptoms, and instead of any of these infections, what they have is subarachnoid hemorrhage, and we need to be cognizant of that. So make sure that you differentiate this diagnosis from the rest as well. And the differentiating points would be that this patient will be, generally speaking, a little bit older patient or adult, and they have a history of uncontrolled hypertension. When you perform lumbar puncture, then CSF will need to be analyzed, and you perform a gram stain on it, and of course white count will be high, glucose will be low, and protein will be up in the case of bacterial infection. So whenever it's bacterial meningitis, which is more common than the other types of meningitis, then glucose will be low and protein will be high. So remember, bacteria will eat the glucose just like we do and will produce protein. So that's how you can remember it. Alright, so this is just a quick picture to show epidural abscess, and then this is another slide to talk about etiology. So whenever you're thinking about meningitis, bacteria will be the most important, and these are the bacteria that cause meningitis in pretty much all different age groups. The most common of all in overall population is strep pneumo. So just keep that in mind. Young infants or neonates can get group B streptococcus as well. Adult patients who are either college students or sexually active can get Neisseria meningitis and Neisseria gonorrhea infections, and then patients with gram-negative patients who are really young and have not been vaccinated against H influenza, which is a vaccine that is offered at 2 months of age, and everybody should get it. But if for whatever reason parents decided not to vaccinate their child, those babies, when they come in and they are really young, we must suspect H influenza, which is a coccobacilli. And then also very young infants can get Listeria infection. That is why we should keep it in mind when we are treating these patients, because there is a different antibiotic combination that needs to be used here. They get listeria because they have not very strongly developed blood-brain barrier yet, and we all know that listeria is a coccobacilli, and it's a gram-positive rod as opposed to all the others, which are either gram-positive diplococci or gram-negatives. All right, so there are, in addition to bacterial, there can be viral infection, there can be fungal infection or TB, and then even chemical meningitis. So of course chemical meningitis will not produce fever, but then the rest will produce some low-grade fever, and of course the course of the disease will be more subtle and chronic as opposed to bacterial meningitis, where patients will have a very acute onset of fever and acute onset of symptoms. Usually within a day or two they present with these symptoms. And then also with fungal and tuberculosis infections, people have some sort of immunocompromised status. All right, so we already talked about all the different age groups, how they can be predisposed to some infections, and then the treatment will depend upon all these infections. So of course just a safe thing to do would be to use third generation cephalosporins or vancomycin if a patient is allergic to cephalosporins. It will cover pretty much everything up until here, but if you're thinking about listeria, then we should use ampicillin and gentamicin, because ampicillin will cover listeria. That's pretty much about meningitis. Let's talk about let's look at the slides real quick. So we have gram-positive cocci look like this, and you know that this is strep pneumo, and then we have gram-negative diplococci that look like this. They're kidney-shaped, and this is Neisseria. And then we have very scattered patterns, so pay attention to this slide. We have a gram-negative coccobacilli, and this is H influenza. You can see they're not paired or in clusters or anything like that. They're just very scattered. And then last we have listeria. These are gram-positive rods, and you can see they are just kind of like this longer shape. Alright, so let's talk about the next infection in the body, that is sinusitis. So that's infection of the sinuses. The good news is that most sinus infections are virus, but there can be bacterial infection. So if the patient develops fever and presents with a lot of sinus pressure, and they can also have a headache and postnasal discharge, then we start thinking about sinus infection. Now you can see that they have a headache as well. So the differentiating feature between this headache and the headache from the meningitis or intracranial infection would be that this will not be as severe, and the patient will not have any neck rigidity. Instead, they have sinus pressure. They also have some sinus tenderness on exam, so when you palpate them you can see this. As far as the tests are concerned, we don't need to do any labs or tests most of the time. 90%+ of the time this is a clinical diagnosis. Patients come in after multiple days of these symptoms, and that's how we can tell that they have sinusitis. Occasionally we can do X-ray or a CT scan when patient keeps on getting these infections or they just become chronic. And we do that just for treatment purposes, for debridement and things like that, not for diagnostic purposes. Etiology, so you can see that bacteria are going to be strep pneumo, that is the biggest bacteria or the most common bacteria, and then you also can get Moraxella, H influenza, and Staph aureus, and then of course viruses are the most common. And you can see a CT scan here, some patchy infiltration in the sinuses showing some condensation here. The etiology in treatment, like specific etiology, would be that most of the cases are viruses, so they don't produce fevers, you don't need any antibiotics, and usually symptoms last less than 10 days. But if they have lasted more than 10 days, then we can start thinking about bacterial infection, and these are the bacteria. And then what is the treatment? Well, amoxicillin with clavulanic acid, which broadens the coverage, is usually very effective. So that is Augmentin in the brand name, and then azithromycin, which is a macrolide antibiotic, and cephalosporins can also be used. Especially if you're thinking about Moraxella, then azithromycin will be very effective. And then if it's a fungal infection, then you can treat appropriately, but again this patient will have very chronic infection, and it's usually harder to diagnose this. Alright, so the next infection is otitis media, or infection of the ear. So when we have a patient with ear infection, usually these are younger patients, and they come in within a day or two with of infection. They have pain usually unilaterally, and this can be absent in small population. People usually have fever, and these children usually are rubbing their ears, or they are upset when somebody touches their ear. On exam, they have red bulgy tympanic membrane. Etiology, again, you can see there is a pattern here. They have Streptococcus pneumo, again the same big bacteria, non-typable H. influenza and Moraxella. And the treatment is going to be, again, very similar. Penicillins covering everything, then cephalosporins possibly covering most of these bacteria, and then macrolides are specifically good for Moraxella infection. So this is a slide showing otitis media. So you can see that patient has a very red bulgy tympanic membrane and air fluid level, and that's how we know it is otitis media.